All right, everyone. Well, welcome. We're going to be doing OCT and OCT angiography and glaucoma tonight. This is a synchronous virtual course. I'll be doing the presenting. Joe's here as our host and moderator. And again, as I mentioned earlier, Joe will be helping me with some of the questions and maybe some pearls with some of the OCTs. And Vanessa, thanks for being here tonight for OEC's Optometric Education Consultants webinar administrator. All of these relationships have been mitigated. You always hear me say, "Look, I don't try and show off here with all these companies." How's a guy in Duncansville, Pennsylvania, be lucky enough to be able to teach colleagues? It's because I get to hang out with some of these companies here and learn and see what's coming. Nothing in here. I have no direct financial relationships with any companies I'm going to be mentioning tonight. I do have a non-salaried financial relationship with Pharmanex. I have a health care registry. I sit as the chairman for diabetes and macular degeneration. That's an outcome-based registry. But here's the most important. The content of this activity was prepared independently by me. No one's influenced me, told me what to say. And if I do mention any products, which I will be mentioning, the OptiView, which is now Visionix, I'm not claiming any superiority or product claims tonight that there's superiority. Joe mentioned that we are owners of Optometric Education Consultant. I just put this slide in here. We're not going to be really talking about the Firefly tonight. Not going to be showing many anterior segment images. But again, a lot of people will ask, which unit I have. I have I think it's called the Avante by OptiView. Now the company is Visionix, but more importantly, the content in this format will be presented without any commercial bias and doesn't claim superiority. The concepts that Joe and I teach can really be applied to really any of the OCTs that are out there. So with the financial disclosures, I always like to point out the financial obligations. I like going to Disney. Disney is not, it's not cheap. So there's the financial obligations with the financial disclosures. So I think most of you know, Joe and I decided to skip the bio here tonight. I practice in Duncansville, Pennsylvania. We have 5 ODs in the practice. This is our building right here. And we have 7 exam lanes. We have an optical contact lenses. I do a lot of ocular disease there. But I always say science is really cool. We don't really have if we didn't have science, we couldn't really help patients, but there's some science out there that's just not ready for the clinical application. So what Joe and I try to do is kind of filter out what's out there and see what's happening and then bring it to how maybe we can use it into our clinic. So that's what we do most of the time. That's kind of one of our core values, one of our filters that we do when we pick a presenter or when we want to present ourselves. So I've been using this slide a lot. We have a comfort zone. Maybe we don't feel comfortable, interpreting OCT. So we have that kind of lack of self-confidence, or we find excuses. And those are here tonight are not finding excuses. You joined to learn this. We go through a learning curve and then a growth curve. And really, I've been listening to some entrepreneur and I'm doing some motivational speaking for some people now. And I kind of learned that there's these 4 C's: confidence, capable, commitment, and courage. A lot of people want to be confident first, but no one was really fitting sclerals in my area. So I had to learn how to do it. I certainly wasn't confident, maybe capable in my mind, but not really sure. So I had the courage. Courage has an uneasy feeling. And I had commitment. And then by doing that, you magically become capable and then confident. So you got to have commitment, the courage that creates capability and confidence. So I know OCT at times creates a little bit of, angina, I guess. And that's our fear zone. And that's why we're here tonight to work through that. So with that said, let's do our number 1 polling question. It's going to be OCT in my office. I'm just curious. You have an OCT. Do you have an OCT with anterior segment? Do you have an OCT with angiography? Or no OCT technology in the office? Just kind of curious with the audience.
All right, good. The Responses are rolling in. I think maybe for the people who are veterans of our webinars, this new platform is a bit different and people are beginning to get used to it.
I see some people answered in the chat box when we did the polling question. How do we see the polling questions? You click on the poll on the right side there. You can click polls. It should allow it to open up. All right. We can probably close this one down.
All right.
Share those results. And let's see, 21% have an OCT. We got OCT with a anterior segment, 13%, and we have 20%. So good. I'm glad the 19% is here without OCT to learn the technology. Maybe they get printouts of it and we can see how those work. So, you know, we have enjoyed our OCTs over the years. They certainly have changed over time from time domain to spectral domain. And now we're getting up to 120 scans per second, getting some really good resolution that's out there. But I have a question is, in glaucoma, which test identifies glaucoma first? Is it a structural test or is it a function test? Which one does it first? Is it structure or function? It's a great debate out there. What is it?
I think it's good that you created really just a binary approach to this one, Greg, so people are forced to make that decision.
I'm going to close the OCT in the office. There we go.
Okay, people are weighing in nicely, Greg.
Perfect. The great debate, structure versus function.
Ischemic versus mechanical. The whole thing about what happens to the optic nerve. Was it ischemic or was it mechanical? Is it structural or function?
You hear me kind of saying this always kind of fits in with this lecture here.
Mm-hmm.
Joe and I belong to the Optometric Glaucoma Society meeting. And if you just think about, we're going to get there, we're going to talk about this axon. And we have a whole society over, in a sense, one axon from the retina through the optic nerve to the lateral geniculate body. So, all right, I think we got a good amount of response. So we have winner at 78%. We have structure. Okay, let's see where I'm going with this now. So there's that great debate out there, right? Rock, paper, scissors, you know, structure precedes functional damage, or does function precede structural damage? It's kind of a, you know, a loaded question. It was a bad question in a sense, because I guess you kind of have to say, if you're going to pick visual field over OCT, that will probably end up seeing, you know, structural changes maybe before that visual field change that's out there. But there are some technologies out there. You know, we have these now new portable ERG VEPs. There is the Raven cone contrast sensitivity test. You know, these are, you know, now function tests that are out there that maybe precede picking up damage before the OCT. So, you know, it's a loaded question. And I guess if you think, we all think visual field because that's what we have in our office. But, you know, we might not have these newer technologies out there, and these function tests can pick up the damage a little bit early. So the, you know, early detection, progression, and at times, if you catch things early enough, you can see improvement to these functional tests, because, you know, it's not to the point where you have no return, you can see the functional improvement, maybe by taking off or lowering the intraocular pressure and allowing that nerve to recover. So that's out there. So, evaluation of acquired color vision defects. Everyone likes to have evidence-based or evidence risk type of medicine, glaucoma, versus normal, and using the cone contrast test that's out there. And this has been since, 2014. This really isn't new, and maybe it just hasn't caught on into the practice. I've been playing around with it in the practice. It's a nice test that's out there. The Ray-Ban cone contrast test. You could do it right in the office. You can see the room has to be dark. It's a monocular test. And it's able to detect early age-related macular degeneration, diabetic retinopathy, glaucoma disease, and retinal disease. And sometimes, depending on the patterns of the dropout, you can see if it's glaucoma or diabetes or macular degeneration. So my point is that, the answer isn't always structure. Within our office, maybe we don't have all these fancy tests. And if you're comparing it again to visual field versus OCT, then you're going to say function, or you're going to say structure, but don't forget there's other functional tests that are out there too. So OCT tonight, get back to the course. We're talking about OCT and OCT angiography and glaucoma. Can we use anterior segment? And the answer is yes. We can use it for pachymetry. I've certainly have, in a sense, replaced my my ultrasound pachymeter with a report like this. I like seeing it because not only does it give me the thinnest area, which is represented by this little asterisk, as we can see right here, the minimal thickness is 569 and 575. It gives me all the different, central, if we can use that number if we want, because that's probably if you're going to go by the ocular hypertensive treatment study. It didn't say the thinnest, it said central. So you can use the 575 and the 586 here. You can also, I like doing it because it kind of gives me an overall what's happening with the cornea. And by checking for, glaucoma and pachymetry, I found other conditions, Fuchs and different, maybe early keratoconus, type 1 keratoconus, form Frust keratoconus by using this. So I like using this. What I have my technician do is she still hits them real quick with the ultrasound. It's a double check, so it allows me to, in a sense, bill for the ultrasound, but I'm using two tests, mainly heavily relying on the anterior segment OCT to give me a kind of a really good aspect of what's going on with this cornea. So, and again, I still do the ultrasound. That gives me the ability, whatever the 765 code is, to be able to bill for this and get those few bucks reimbursed. But you can still do pachymetry via ultrasound if you'd like. You could use something like this test here that's does the anterior segment, posterior segment, and then since it knows the anterior and posterior floats, not the posterior segment, but the anterior float and the posterior float. And since it knows the distance between via optical, the way it's bouncing off, it'll give you what's an optical reading that's out there. You have to be a little careful with these devices. The cornea has a scar. The cornea is a little bit edematous. It might hit the edema, it might hit the scar and bounce back, and you might, in a sense, get some really thin corneas when that happens. So we like, I like this because it's going to be super, super accurate, right? Because this is going to be perpendicular. Every time Sarah, who's my technician, and everyone always hears when I lecture, says everyone needs a Sarah. Maybe everyone has a Sarah-like that's the right and left arms in the office. When she does this, they're always a little bit thicker than the central cornea thickness. And that's because the OCT is able to get these, right down the center, perpendicular. And whenever you go a little bit diagonal, a little bit off, that's a little bit longer. So you're going to be a few microns, thicker. that's out there. So this is just one way of maybe measuring the that central cornea thickness, getting the overall health of that cornea by using your OCT. And I'm still going to talk about this. Joe knows I've been talking about this now for at least, 10 years. But, he's heard this case so many times. 55-year-old men, it's two men. One has a 500 cornea and the other one has a 600 cornea. And just ask yourself, what is, and it's taken with Goldman. So what is the true IOP here? Is it because it's thin? Just ask yourself, is if it's thin, 21, it must be 24. And this one here is thick and it was 21, so it must be 18. Or is it that you don't know? Or is it 21? What would might have been a good polling question, but ask yourself in your head, what would you do in your practice? 521. The answer is leave it at 21, right? You don't want to adjust up or down. The reason being is that the Goldman tonometer is influenced by a lot of things. The top three here, like there's 17 parameters that the Goldman tonometer is influenced by. Corneal curvature, cornea rigidity is the big one, and then cornea thickness. So cornea rigidity is we make a huge assumption that a 500 cornea is rock hard, and is mushy. We make that assumption, that a 500 cornea is mushy because it's thin, and a 600 cornea is, now I can knock rock hard because it's thick. And there's been a lot of tests done on the cornea where there's been cornea 600 really mushy, and there's been 500 micron corneas really, really rigid. So what we don't want to do here is make that assumption and go the wrong way. Because if we go the wrong way, then we might end up maybe not treating the patient, or we might end up treating the patient when the patient really didn't need to be treated. So all in all, still don't adjust those IOPs up and down. From time to time, I'll have people say, hey, I still get letters from people saying that they adjusted up and down. Okay, that doesn't mean they're right because you're getting the letter that's out there. So another way that you can use your OCT is to check the angles. This is my eye. I had LASIK done years ago. I was a -6 myope. You can see I'm wide open. You can drop, the calipers in here, and you can kind of get the way of the angle here, and you can see that I'm, 46.54. And here's Schlemm's canal right here on the OCT. You can see how it's transitioning over the cornea, and then there's Schlemm's canal. So trabecular meshwork, and then going into Schlemm's canal. But less than 15 degrees is kind of the little rule of thumb that I use in the office. I use it with my surgeon that comes in. This is kind of where I'll do gonioscopy. Gonioscopy, when you do it, I do it on every patient because it sees 360 degrees. It's going to tell me what's going on with the pigmentation of that angle. But there's times whenever I'd like to see with the lights dim. When you do gonioscopy, you're shining a bright light in the eye, it constricts the pupil. So there's times I just like to see what's happening with this angle with a lot of dim light and grabbing an OCT to see what's happening here. And we just kind of come up with if I do gonioscopy and I'm just barely seeing trabecular meshwork, maybe Schlemm's canal, and we have this kind of less than 15 degree type of angle. The surgeon says, yeah, if you send that to me, I'll probably do a peripheral iridotomy on it if they're hyperopic, small eye, and we want to prevent angle closure. Like this one here is a little bit wider. So it's kind of hard to kind of predict, like, where would you put this line? Would you put it down here to catch this last hump here? So sometimes it's a little bit of a little bit of a guessing game there. For this one here, if I would maybe bring this one down and run it out, you would say that angle might be a little bit larger. But it's one way to maybe just to double check your gonioscopy, making sure that you're not getting someone that's going to be close to maybe closing off an angle. And here's what an angle closure looks like. So you can see here that the iris, you can see iris is bulging forward here. The pressure is building up in the posterior segment. The anterior segment, it's not really getting much aqueous in it because everything's kind of sealed off. Everything's kind of bulged forward here. And this is great because we caught this super early. And the patient, you can see even the cornea is not that swollen yet, which can happen with these when they get high pressures that are out there. You can also use your anterior segment. This is kind of a little, this is not for glaucoma, but don't forget, this was a person that came in that, you know, I thought that they were kind of maybe looking for opioids or something. They're in severe pain. They were making some model with the something or carving something with a really super thin bladed knife. And, you know, they actually slipped and, you know, and cut their eye. And I finally saw this and had some fluorescein, but you can see here, I'm like, oh, geez, you know, that's pretty deep. That's a nice little RK incision, 407 microns, and the total part of this cornea was 595. They're definitely close to 2/3 of the way through that's out there. So don't forget, you can use your OCT for, you know, here's a herpes lesion that was just playing around with it. You can see right here, I cut right through it. You can see where the infection is. You can see how the signal's being blocked. You can see what's happening with the cornea. This is just another cut through, again, where this lesion is on the eye. This was someone that had an infectious keratitis, battled this for a while. We had to do PCR testing to figure out what was going on with this and get the appropriate treatment. We were watching this lesion. You could see the cornea was thinning. I was making sure that they weren't going to perforate, watching them closely using, you know, the OCT technology here. The wound is nearly closed. You can see how the epithelium now has grown across, which is nice. And it's just a nice way. And you can see the ulcer is now not as dense and the signal is able to get through. And we battled this thing for 10 weeks and you know, had to get the appropriate treatment for this person. So that was just a quick reminder there. So Joe, any comments? I know that you and Lori did some of that studies early with the pachymetry and anything you want to make with closing of angles and using anything OCT anterior segment wise.
Well, Greg, you were spot on about the anterior segment OCT giving you the best I can say the best thickness, so to speak, because in free space that, you know, if you're off, you know, you're not perfectly orthogonal like this, you're going to be going through thicker. Now, what we saw during our study, which we published in, I think, OVS several years ago, was anterior segment OCT was uniformly thinner and much more reproducible than ultrasound pachymetry. But Greg, if you back up a little bit, there's a nice OCT angle I want to point out. I'll stop you when you get to it. Is there another? Yeah, that one. No, the other one. Go forward.
The closed one.
Yeah, this one right here. Yeah, this is excellent. And actually, if you go back one, I think this is excellent. I don't think we, you know, if you want a guideline, you can try to put the calipers in there, but that's highly speculative and subject to you know, to what people think the structures are. So I don't go by the numbers or anything of that. I just kind of look at it where the one on the right is, you know, that's open, and the one on the left is a little more dangerous, so to speak. I don't worry so much about the numbers. I just like to use this to see what the iris, lens, and cornea relationship is. Now, if you can go forward, Greg, this is a great example of what would be closed angle. But this is only one very, very small cut. We don't know what the angle actually looks like 180 degrees. It may be actually more open where there would be structures. So this is a valuable adjunct to gonioscopy, probably as accurate in many ways in terms of subjective approach. But this is a single cut. We don't know what's happening 100 or 90 degrees away. So valuable adjunct, but not a replacement for gonioscopy, and that's really it.
Perfect. Yeah. Well said. And thanks for that reminder and tips. All right, so that's the anterior segment. Let's jump into some nerve fiber layer. Let's jump into some ganglion cell. A lot of the layouts, remember we're looking at the nerve fiber layer here. We're looking at the ganglion cell complex. And, let's remember that, these are ganglion cells, and this is just a picture of a ganglion cell. And what I want to point out is this cell body is here, surrounding in that para-E macula area, the foveal pit. Remember, where it's free of the ganglion cells. And so just off to that side in that para-E foveal area is where those ganglion cells start to reside. And then that forms that axon, right? And that axon comes through the nerve fiber layer, through the laminar curvosa, becomes myelinated here in the outside the laminar curvosa into the optic nerve. We finally make it through the foramen and then into the optic chiasm, and we know some of the fibers cross and go straight back. But then we finally synapse here at the lateral geniculate body. And again, this is what I kind of say is we formed a whole society for 20 years, been going pretty much, never really missed a conference. And really over this axon, this ganglion cell and this axon, we got a whole society that has formed to try and figure out, like Joe said, is it ischemic? Is it crushing? Is trying to figure out all the different risk factors of why this axon. And we're going to talk ganglion cell, why these thin or why this axon dies. And that's what we're evaluating whenever we do, the nerve fiber layer analysis, or we're doing that ganglion cell analysis out here. Again, foveal, para-E foveal area, and just seeing if they're thinning from maybe a glaucomatous disease. But remember, not all ganglion cell and nerve fiber layer loss has to be from glaucoma. It's just that glaucoma is the number one optic neuropathy that occurs. All right. So this is just one of the cuts that's out there. This is what OptiView uses as for their ganglion cell complex. I think all the instruments are very similar. In their ganglion cell complex analysis, they use nerve fiber layer, ganglion cell layer, in the inner plexiform layer. And I do open this up from time to time, one, to make sure that things are segmented properly. I like to make sure that, it's, in a sense, finding where that inner plexiform layer is, making sure that there isn't any vitreomacular traction, making sure that it didn't get kind of squirrely and kind of couldn't find it, and it's got close, and we can move those segmentations if needed. This one is very well segmented. And what I like to look at is also when I think someone has glaucoma, this is a patient with glaucoma, and you can see how healthy the ganglion cells and that nerve fiber layer, ganglion cell layer, and inner plexiform layer is. And over here, this is a patient with known glaucoma, and we can see the thinning compared to, maybe someone that doesn't have glaucoma. This is a glaucomatous person right here. So I like looking at these scans. I like opening them up, make sure things are segmented properly. And then, okay, we're going to treat you. Maybe one quick little pass before making that call, just to make sure things are segmented and there is atrophy. Joe, any comments on segmentation or any of these cuts, or move on?
No, I disagree with you, Greg. I think it's vitally important to look at, make sure that it's good quality, there's no missing data, and it's well segmented. And that's something that maybe makes some people a little bit uncomfortable. Maybe they're not used to doing it, but it is actually something you should learn how to do to make sure that it's proper segmentation.
Yeah, especially
Otherwise, you'll get faulty data.
Faulty data, and then maybe making a decision on that, right? Starting a treatment on something that's maybe faulty data. All right, polling question number 3. I want to know if this ganglion cell loss, this red, this yellow, these yellows down here, is this thinning of the GCC most likely from glaucoma? Yes, no, I'm not sure, and that's why I'm here. Is this ganglion cell loss, which has got a lot of red, a lot of yellow? Is it from glaucoma? Not a lot of history. I realize that. Kind of maybe taking a shot in the dark.
Okay, people are rolling in. Give a few more seconds, see if anybody wants to interact here. All right, everybody seems to have stopped, so I'm going to close and display.
Anything happening in the chat box here, Joe?
I will take a look.
Which instrument and brand are these from? Help me out, Linda. I'm just finally jumping over here. Is an OCT pack imagery reading considered ultrasound optical, and is it billable? No, it's really not. It has its own code, 92132. I think is anterior segment, 3.3, I think is optic nerve, and 3.4 is retina. So that's why I do the ultrasound with it. Again, it's a double check, but it again kind of frees me up to being squeaky clean, being the third party chair for the POA for 20 years. I don't want to be the person that gets hit with that. What is segmentation? That's a very good question. I can go back one slide here. Segmentation is where these white lines are. Thank you for bringing that up because I talk it as people understand a lot of these concepts. I have worked with these OCT companies. Basically, the instrument is putting in this white line. It's segmenting out, right? It's figuring out where the RPE is. It's figuring out where the inner plexiform layer is. It's figuring out where the internal limiting membrane is, and it's segmenting, teasing out. So what can happen is you see this white line, and all of a sudden it drops way down, and maybe up against the inner plexiform layer. So segmentation is these white lines kind of where segmenting out or teasing out some of the different structures of the retina. So, all right. Okay, I think we're caught up. We caught up on the questions, Joe. That I kind of took a quick look. All right. All right. How do we do with our polling question here?
I think we did fairly well.
Let's see. We've got some yeses, got some no's, and we've got a lot of people saying majority.
That's why I'm
not
here.
sure why I'm here. So, all right, perfect. All right, I'm not going to give you the answer yet. I'm going to teach a few concepts, and then we're going to come back to this picture a little bit later. So stay tuned. I will show you. So here's this is some of the things I've come across with teaching OCTs over the year. We have green, yellow, and blue disease, red, green, yellow, and blue disease. Is it physiologically normal, or is it we have some structural damage going on? So here's some hints. Diseases of the body are usually bilateral. Think of like arthritis. Yeah, I have it in both elbows, but man, is it worse in one elbow than the other? We have people, our patients that come in and have hips. Well, I had one hip replaced. Looks like the other one will be in 3 years. So it's bilateral, usually diseases of the body, but it's usually asymmetric. And luckily, glaucoma falls into that bucket 99.9% of the time, like ivory soap. It usually starts in one eye. It's in both eyes, but maybe more advanced in one eye than the other. So it's bilateral, but yet asymmetric. I'm talking the primary open angles, the angle closures, maybe some of the secondary pseudoexfoliation, the pigmentary glaucomas. They are in both eyes most of the time and asymmetric, But these rules are, applying to that kind of that primary open angle glaucoma patient. So if things are symmetric, it's probably not disease because it's going to be rare to have the disease acting equally. Now, I'm sure there's a case out there that someone can, say, hey, look, I had this case, but in the everyday heat of the moment, if it's bilateral and symmetric, it's probably physiologically normal. And if it's asymmetric, it's probably some type of disease. So with that being said, when looking at the ganglion cell complex, I look at these all day long. We do a pretty good wellness package in our office. So I see them all day long. And what I learned is that for this, what I want you to kind of write down if you don't have an OCT, and we teach these concepts and you can then apply it to your OCT, is that it's pretty much 85 to 100 microns, with the average being about 92 to 95 microns when looking at these all day long. So what I'm talking about is whenever I get a wellness kind of scan at my office, I always start with the ganglion cell. I kind of have in my head that they should be between 85 and 100, and they should be symmetric. And when I was working with OptiView and some of the KOLs, not that we couldn't do the math, but it was just a real quick scan to look at these numbers and see 2, 1, 2, 1, 0. So 98, 98, 98 within the eye. You can see 1 micron difference between the eye. Between the two eyes, we can see that it's 2 microns, 1 micron, 2 micron. So I don't scratch my head, and that's why we wanted the number, until these numbers to start to get about 10 difference, 10 microns difference. That's kind of my rule of thumb that I use. Joe, do you have any rule of thumb when it comes to the ganglion cell layer or nerve fiber layer? Is your threshold higher, lower, about the same when it comes to looking for that asymmetry?
It's about the same. I mean, keep in mind you can have asymmetry and still be in the green. Just what one has dropped down, and it still is within the normative data range. I'm thinking probably around 10 is something I have to consider. But again,
And we'll
I want to be reproducible too, though, because you can just have an acquisition error.
So we're looking at here with this, and this is a normal case. I'm just kind of showing you the symmetry that occurs that's out there. So again, remember that 85 to 100. So when I see these 85 to 100 and are things symmetric, boom. Now this is proprietary to OptiView. Again, I'm not claiming any superiority out there. This focal loss volume, it's a percentage. I really don't know the numbers. And when I was talking with all the scientists and the creators of this, basically green is good, yellow is caution, red is bad. If this is flagged yellow or red, pretty high suspicion for glaucoma, and this is just the general health. So this might be low in someone that's a pretty high myope that's out there. So that's just looking at the ganglion cell complex and just kind of applying those numbers. So let's start looking at some patients. Here's a 46-year-old woman that comes in. I'm going to say she has red and yellow disease, kind of a lower myope, history of thyroid dysfunction on a cholesterol med. Pressures are 15, normal. And we come and we see this person here, and they have all this red going on in their retina here. It's like really, really thick retina. What's going on? So that's why I like looking at the ganglion cell complex first, right? So the ganglion cell complex here is green, but it's 110. But look how symmetric, 110, 111, 110, 1 micron difference, 110, 109, 111, 2 microns different, 0, 2, and 1. But it's at 85 to 100. Man, we're in that bonus range that's out there. Certainly no focal loss volume, because focal loss is, remember, glaucoma kind of grinds down in that one area. So it becomes very focal. If that loss is focal, it's a high suspicion for glaucoma and the general health. So here we're using green is good, yellow is caution, red is bad. But over here, green is in the middle. I call this the Goldilocks, right? Too cold is blue, just right is green, too hot or too thick is red. So too thick, just right, too thin. And we're really thick retinas because of how thick the ganglion cell is. But again, look at the symmetry. 329 to 330, 1 micron difference. 64 to 59, 5 micron difference. 294 to 293, 1 micron difference. 350 to 352, 21 to 18. Now make sure you go inside 359 to inside 357. You don't want to get the outside because you might scratch your head and go, ooh, look at their asymmetry. Go inside to inside, 335 to 335, 342 to 336. Again, this is all symmetric, all normal. Nothing is happening here. Nothing's causing this retina to be thick, epiretinal membranes or macular edema. This one here is that yellow and red disease, all normal physiology, but the ganglion cell complex helps solve it by knowing a few of those rules. So I'm looking for things like edema when you see redness that's out there. That's why you have the scan to look at itself and to look at. And we can look to see if there's an epiretinal membrane creating some traction and some cysts and some fluid within there that would cause some type of redness. But we don't see that when we come up here and look at this case. Here's a 63-year-old woman with red, yellow, blue, and green disease. She's got it all, right? She's plano, presbyope, normal IOPs, anywhere from 2011 to 2015. So we jump down here and we see the blue, we see the little bit of red, we see some yellow, there's some red. Okay, is this, disease going on? So let's jump down in here and take a look. Remember, 85 to 100 is my limit, or is my range, but symmetry kind of trumps. It kind of trumps the yellow or that 85 to 100. So when I look at this, I see 83, 81, 85. Okay, 4 microns. There's 81, 81, 82. That's 1 micron difference. And then we look and we see 203. It's saying, it's really not focal. It's not really kind of grinding down, but maybe in this area, just kind of a general thinning of it. So when I go and I look up here, I'm not really convincing myself that this is a glaucomatous type of condition. Now, remember, there's some pretty cool stuff happening with other neurogenic diseases that are out there in Parkinson's and Alzheimer's. Maybe as I look back and look at these cases, are we picking up in any of those types of conditions? We're going to have to stay tuned. But you see this blue here, we have 254, we got 254, we jump over here, 265, make sure we go to the inside. Look, 265, but it's green. So the algorithm is more than just the number. It takes in a whole bunch of surface area and thickness. So we have one here that's saying 265, but it's green, 265 here, but blue 246 and 248. So there's a lot of symmetry here that's going on that would not, in my mind, with all this yellow and red, would not cause me to say, okay, I need to investigate any further. Then we follow the patient up a year later. You can see here the dates, almost exactly a year later, a year and a couple of weeks, gets the scan. And look, it's almost like one of those ink blots. You almost can fold it over and unfold it. Look at the symmetry, and then check out the symmetry this year. 81, 81, 81, 81, 82, 81, saying not glaucoma, just some general thinning, some loss right there. So here is here is just something that's physiologically normal. Here's another patient here, 58-year-old with yellow disease, low hyperope. IOPs are normal. I have a little reminder here for me to pay attention to the focal loss volume and global loss volume. So here's what I see when we look at them individually, and 82, 82, 81, saying, okay, not glaucoma, just generally thin, 81, 81, 81, not glaucoma, just generally thin. So when we put them side by side here, we see a lot of this. Again, it almost as if you would fold that as an ink blot and unfold it. You got this red corresponding, yellow, and this kind of little arm and that little arm that's going on. So physiologically normal, I would say, not glaucomatous or maybe associated with any other condition that, at least now that we're aware of. Here's a 40-year-old man with red, blue, and green disease, a higher myope, normal pressures. And when we jump in here and we take a look, we're seeing lots of blue, a lot of red here, a lot of red here. Let's see if I have these together. Yes, right here, 22 months apart. So I know I clicked through those quick, but here they are. Here's the 1 year and then 22 months apart. Let's see what happened. We can see here, back here, it was flagged red, but it was 80, 80, 78, 78, 82, 81. But look, zero difference, one difference, four difference, three difference within the eye. It's saying not glaucoma, it's just general thin. Remember, he's a higher myope. And these normative databases didn't include higher hyperopes, higher myopes, tilted disc, obliquely inserted disc. And like the highest normative database that's out there in a normative patient, a normal patient, I think is like, 500 patients, but they were all normal. No diabetes, no tilted disc, no obliquely inserted, not high hyperopes, not high myopes. And that's going to create some of these yellows and reds because those people weren't in studies. But you can see here, very symmetric, saying not glaucoma, just generally thin. What happened 22 months later? Well, not too much. We're still sticking around 80, 79, 77, 77 compared to 78, 82 previously. We're at 83 now. We were at 81. We're at 80. And we have 6 and 3, 1, 0, 3, saying not glaucoma, just generally thin. So all of this yellow and red is just physiologically normal and, not in a sense a glaucomatous condition. Here's a patient that came in, 79-year-old woman with diabetes. And look at this type of, loss. Look at that. It's almost like again, I keep saying ink blot, but let's go up here and take a look. 77, 77, 77, 78, 77, and 77. Super symmetric, saying glaucoma, saying generally thin. Again, this could be someone maybe in one of those neurogenic diseases, or it's just physiologically normal, but I wouldn't classify it as glaucoma. All right, so those are some things that are just normal that can light up red, yellow, blue on these. Now, let's look at a bunch of known glaucoma patients, just rapid fire. Okay, so again, we're going to go up here and take a look or down here and take a look at first the ganglion cell complex. We got 102, 102, 100. We got some bonus on this person, right? 101, 104, 104, 0, 1, 0, 4, and 3. We have all green, nothing glaucoma, just general. Jump up here to the nerve fiber layer thickness. We haven't really talked yet, but this is the glaucoma prone zone. That's superior temporal, inferior temporal. Glaucoma is really not like a nasal disease. It's superior temporal, inferior temporal, not really a temporal disease. Kind of in these areas here is where we want to concentrate. And whenever we look, we can see that there is symmetry. Here's the nerve fiber layer, 115, 111, 119, 123. Now, I don't really have a nice range for this because remember, there's macro discs, micro discs, and it's all depending on where it's measured, how far away or how close. That ring is always the same size. So if you have a big disc, that's going to affect it. If you have a smaller disc, that's going to affect it. So I don't really have any rules of thumb other than I scratch my head when it starts getting about 10 microns different. The 10 micron difference works on both sides. It works on the nerve fiber layer and it works on the ganglion cell. So this is a normal one. Let's look at some patients with glaucoma. But Joe, I'll pause there. Do you have any pearls that you would like to throw in at this time?
No, what I think, Greg, is you're saying is when you're looking at these, it all has to make sense. It all has to fit with the clinical picture. What you have there is, I think, visually impressive because I look and I see symmetry. Even if I don't look at the numbers, I see symmetry. I don't see anything that looks funky, like maybe you caught a PVD or something like that. No evidence that there's any sort of maculopathy. Put it all together, and you can use this. But I look at this, and this is very, very normal to me. But I like that thickness map. I like looking at that, and what does my eye see? Do I see a difference right and left eye? And irrespective of the numbers, we have to consider now: is there a reason for it to look different? Is the nerve kind of tilted a little bit? Is Is it maybe a bit of an off capture? You know, are things shifted a little bit because one nerve was center, the other was not quite as center? So these are all things that I consider here.
Perfect. Great comments. Overall look, I like that. Step back and take a look at it. Kind of like here, taking a step back and look at it. This doesn't look like this over here.
Mhm.
So let's take a deep dive. Now, these are all known glaucoma patients. So there's nothing here that I'm trying to fool anyone with. I just kind of want to show you how some of these concepts work. See, now we have a 15 here. This is going to cause me, if I'm scanning them for the first time, I need to try and figure out why there's asymmetry. So looking at our nerve fiber layer, we're catching a 15. We're seeing some numbers here, 83, 84, 81. Then we jump over here and we see a 72, a 69, and then we have an 86. Geez, we got a 17 difference here. We got a 15 difference here. This is the optic nerve head analysis. It can kind of tell us micro and macro disc, but a lot of this stuff is plugged into some of these percentages and greens and yellows to come out. So I typically just look at the nerve fiber layer, look at maybe the nerve area just to see maybe a macro disc, micro disc. But jumping down here, let's go see what we see. 92, 93, 92, but then we come over here, we have 87, 78, and now we have, again, that 15 micron difference. You know, a lot of times people ask, is it the ganglion cell that dies first, then the axon, or is it the axon and then the ganglion cell? And, you know, I've seen both. You know, I've seen where it's the ganglion cell is showing up pretty sick, and then the axon seemed to be hanging in there, and then they kind of maybe die off later. And there's times where I've seen the nerve fiber layer thick or thinned out, and then the ganglion cell is still kind of hanging in there. That's out there. So I don't think there's a one or the other that dies first. And then, you know, we come up here and this, you could start seeing the symmetry, the asymmetry that is occurring. So quickly looking, we can see that the glaucoma is worse in the left eye, in the right eye, in that glaucoma prone zone, that superior temporal area. Over here, maybe not so bad here, and not the inferior. And that's kind of matching up with kind of how that's that superior ganglion cell complex that we showed earlier. Here we can jump over. We got glaucoma in both eyes. You can see the asymmetry. Joe was mentioning about just looking at the colors. We got the glaucoma prone zones going on here, worse in the left eye than the right eye. We've got a 12 difference, a 4 difference, a 20 difference. We can jump down here. We got a 12 difference and 18. We still got the right eye kind of in that green range. And this is what Joe was kind of mentioning here. You know, this normative database has a lot of play in the green. We can see that there's glaucoma here, and we're still lighting up, and even down here, we're lighting up green here, and this whole ganglion cell is lighting up green. This is disease, so we just can't go by just the colors. Joe, you brought that up a little earlier. Do you have any comments you want to make in this arena here while this is green?
Well, like I said, you're correct. There's a large range of normal. I don't know that there's anything different that I could add here. You have a lot of things. The GCC in the right eye is not nearly as bad as the left, and hence the reason you may have some things that are in the green. And it actually looks better than I would expect based upon the nerve fiber layer in the right eye. You've got a significant wedge in the right eye superior temporal, even a little bit in inferior temporal. I would expect probably a little bit more, and maybe with time that GCC in the right eye is going to start catching up to the nerve fiber layer and start looking a little bit more like the left GCC.
Yeah, so this one here looks as if the nerve fiber layer is more advanced than the GCC. That's a good call.
But the important thing is the correlation. You see where the defect is on the nerve fiber layer, and you see the defect on the ganglion cell complex, and recognize that's really all one defect, that is contiguous.
Right. Again, another one here. Now instead of superior, a lot of people say, oh, we start superior, and not really. Here's an inferior. inferior temporal. You can see that the ganglion cell now is outpacing, right? This one here, it seems as the nerve fiber layer is outpacing the ganglion cell. Here we've got the ganglion cell damage showing up and maybe outpacing the green and red that we see here. When we jump up to the nerve fiber layer, these are sevens, all right? So maybe if I was looking at that, so maybe scratch my head, it's getting close to 10. Down here, we got a 6, an 8, and a 4. It's saying with the focal loss volume, we have glaucoma. It's not just general loss. So we can see we got glaucoma in both eyes, a little bit worse in the right eye than the left eye here. But we can see, looking at the T-SNP values, things are relatively close.
Look, actually going back one, Greg, right there. Now, if I'm just looking at the thickness, I'm ignoring the numerical and statistics. The right and left eye nerve fiber layer looks actually fairly symmetrical. Now I expand out and I look at those numbers. You can see one on the left is in yellow inferior temporal, the other one is in red inferior temporal. Okay, so that tells me where to look on the GCC, and on the GCC inferior defects, it all matches. So that even though it does quote unquote look somewhat symmetrical, there is that concordance between the ganglion cell complex and the nerve fiber layer, telling you that this is all probably one big defect in each eye.
All right, and I'll go quickly through these. I think we've got to the point where we're able to see, we can see a 7, a 3. We got down here an 11 and an 18. Here's the ganglion cell, huge dropout, the kind of focal area right here. Look at this dropout. Asymmetric, worse in the right eye than the left eye. So again, driving home the concept, glaucoma is bilateral, primary open-angle glaucoma is bilateral, usually asymmetric. In following over time, what I want to point out is that these gray bars are the confidence intervals, and you usually want them a little bit tighter. Usually in the ganglion cells, a little bit better. It's why I use this one. It's a little bit better. It's usually like this. It's a little bit tighter than the retinal nerve fiber layer, because when they're gathering the ganglion cell, hey, look straight ahead, use your fovea, look at the dot, as opposed to if you ever had an OCT done, if your nerve fiber layer, you kind of have to look nasally into the instrument, depending on what eye you're using, and it's a little bit harder to maybe get that eye lined up. So typically the ganglion cell is a little bit more reliable since they're using their fovea. Maybe there's a bad scan here in one of these that's throwing off that confidence interval. Maybe go back and look at those segmentation lines. This is typically what we see here, is it's a little bit tighter in those confidence intervals. And following patients over time, you can see that the gray may be a little bit wider. It's a little harder to look. Again, a little bit tighter here than it is here. So the ganglion cell, look how wide these confidence intervals are. I'd go back and maybe see what's going on, but you can see that there's definitely some type of glaucomatous action in this over here in the right eye compared to the left eye. All right, and this is just some of the strong family history that we're just following over time, and we can just see that the rate of change is relatively stable. You're going to get a little downhill trend, but we don't want that trend going too fast in these glaucomatous patients. So, Joe, can we do this polling question here?
We can do the polling question, and we'll do it while it's coming in. We're going to have a few questions to answer. So poll 4.
Okay, poll 4 is basically which OCT here, using those concepts now, is most likely glaucoma. Is it this number 1 here, or is it number 2 here? Where they both have damage, they both have red and yellow. This one here is red and yellow. Which one here is the glaucomatous OCT? No history.
Okay, Greg. So that's all. We'll let that go for a bit. Question: that 85 to 100 average normal range is specified. Is that for the whole GC or just for the RNFL?
85 to 100, that was for the GCC. And that's on an OptiView, me looking at them, day after day. We have a wellness program, but they're teaching that concept because you can do the same thing with your OCT and try and figure out what's normal. But that's the nerve, that's just ganglion cell. I like knowing what the ganglion cell is because if it's thin, then it's going to make the retina thin when I look at the retina map. So like here is a retina map. This GCC is thin here. This could be showing up blue over here. It's not, but because this is so thin, this can start showing up blue. If this is thick, this can show up red. I showed an example of that. That's why I always like looking at the ganglion cell to kind of see how it's going to influence. But that 85 to 100 is only here. There's a lot of variation with that nerve fiber layer, again, because it's that same circle. You can have a small optic nerve, and that mean that circle is going to measure a little further away. If I have a bigger optic nerve, it's going to be a little bit closer to where that nerve fiber layer is going into. So I don't really have a rule of thumb for a number for the nerve fiber layer. Plus, there's split defects. There's a lot of things that can happen. Tilted nerve fiber layers, tilted disc, obliquely inserted discs. So I don't have a number that I would use comfortably or give to the colleagues for the nerve fiber layer.
A great question. When you say generally thin on the global loss volume percentage, what are the normal ranges?
Yeah, so when you come down here to global loss, you don't really look at the percentage. It's a very convoluted number. When Larry Alexander was alive, he was trying to, in a sense, explain it. And he was just like, Greg, you know what? It's a percentage. It's taking in a lot of, it's got a cube worth of data. It's taking in all this different parameters. And basically he said, don't ever look at the number here. Just look to see if it's green is good, yellow's caution, red is bad. So in the focal loss volume, it's very specific for glaucoma because glaucoma drills down, like right here, it keeps drilling down in this area. That's why this one is yellow. This one is red because it keeps drilling down. Glaucoma keeps drilling down that same area as a focal loss.
Another question, is it better to look at the RNFL report instead of the GCC report because the GCC report is more prone to red, green, and yellow disease?
No, I think you kind of what Joe mentioned earlier, that kind of all has to make sense, right? So this is the glaucoma one over here on this side. You can kind of see that the nerve fiber layer kind of goes over to the GCC. I like it when they put this map right here because it just, you can see that just kind of goes right over to the ganglion cell. I guess if we move this circle up here, that nerve fiber layer kind of matches that GCC there. So they both have to make sense in glaucoma. Not one outwins the other in mine. You might think that the GCC might be a little bit more accurate since they're using their fovea, but I use them both.
I think it's important to use them both, but I think in terms of anatomic variability, the nerve fiber layer is more variable. That's why we started looking at the GCC. Do you ever start treatment on the GCC alone? That's a good and loaded question. In fact, that might be another lecture, Greg.
That could be a whole other lecture. No, I mean, it's got to make sense. I mean, when we treat glaucoma, I'm looking at the optic nerve, looking, maybe taking a picture of it, doing a visual field. GCC alone, there's so many variables. Again, there's GCC loss can be from Parkinson's disease, Alzheimer's. It could be from a lot of other conditions that are out there. So I would not make the decision on an OCT alone because it's not just for glaucoma.
And how fast is too fast for GCC or NFL changes, in your opinion, Greg?
Yeah, it's that's another one of those loaded questions because some glaucomas are fast, some are slow. We've always tried putting a number to it. I really haven't come up with a good number over the years. Maybe the other OCT glaucoma gurus out there would put a number to it. Joe, I know you're well versed in this area. Do you have any number that you would put to it? I mean, I don't really have anything specific other than going downhill too fast is just not good. So
no, I don't really put a number on it. A lot of it is dependent on, among other things, patient's age, severity of disease, Is the same age-old question. What about visual field? What changes too fast? And most people say 1 decibel a year is too fast. Well, it all depends on the patient, how old they are. If you're seeing a more than 10 micron difference in the GCC on the initial OCT, are you making a decision, diagnosis of glaucoma and/or progression, or are you doing another OCT to show repeatability?
Yeah, I'm going to do a lot of things when that happens, right? I'm going to do a visual field. I'm going to repeat the OCT. I'm going to examine the eye, maybe take a photo. I'm going to open up this OCT and look around a lot of other scans because, there could be an epiretinal membrane. There could be a vitreomacular traction. Remember, that vitreous is alive and it can really mess up and create asymmetry. So again, these instruments are not just, it's just not a glaucoma diagnostic tool. You can pick up a lot of other conditions by doing it, which can influence and create that asymmetry. The asymmetry tells you that there's something going on. It could be glaucoma, but there also could be an impending, again, a PVD. There could be vitreomacular traction, epiretinal membrane, macular edema, retinal attachment. There could be a central serous. So we have to examine and take a look and see what's going on.
Yeah, Greg, my phrase is none of these instruments are Silicon Valley Rumpelstiltskins we put in a straw and get out gold. One more question. In your experience, you see GCC or NFL OCT thinning first in early glaucoma?
Yeah, that might have rolled in a little bit later. We chatted
Hmm.
about that again, but worth echoing
Yeah.
is
Hmm.
that they both we showed an OCT earlier where the nerve fiber layer was worse and the GCC wasn't as bad, and we showed the GCC being bad and the nerve fiber layer being good. So both can happen. That's why they're both on there. Joe mentioned there's a lot of variability to the disc and tilted and obliquely inserted. So where the macula, in macular degeneration or maybe pathological myopia, there's less variation that's out there. So both, in glaucoma, the nerve fiber layer can go first, the GCC could go first. That's why you got to evaluate both of them.
Actually, Greg, when you did an earlier polling question, you made a binary choice where they had to commit. I think the answer to Sharon's question is it depends.
Mhm.
All right. Well, I forgot we did a poll.
Yeah, so I launched it.
Hmm.
I opened it up, and a lot of people, 92% said number one. That is correct. There's your asymmetry. This is the one that we opened up with. And we had a high volume amount of people saying it was glaucoma at that time, and now we only have 2 people saying glaucoma. This is just way too symmetric. We have the symmetry here, 81, 82. We got 1 micron. The focal loss volume, again, it's not grinding down. It's just generally thin. I would say this is just a physiologically normal, and that was the one I said, I'll get back to you and show you later. We did go over it in one of these scans earlier in the presentation too. All right, so I'm going to close it up. I'm going to close the question, and we're going to do a little bit of OCT angiography. Now, I love OCT angiography. I love it for patients with diabetes. Diabetes is a capillary disease. So if it's a capillary disease, we probably should be looking at the capillaries. We know that macular degeneration has a choroidal neovascular membrane. I like it looking for choroidal neovascular membrane. To kind of use Joe, Joe and I have been friends for years. It's kind of for glaucoma. It's not gonna really change my it's not like, oh my gosh, I can't live without my OCT angiography. For diabetes, I mean, it's a capillary disease. Why are we looking at structural changes when it's diabetes? We should be looking at the foveal avascular zone, seeing if it's expanding in diabetes. We should be looking at for choroidal neovascular membranes. For glaucoma, it's pretty good. All right. It's another piece of equipment maybe to help me make that diagnosis, or more importantly, where it's helped me over the years, my progression analysis to see if this person is progressing. So it's another data point in this optic neuropathy that we call glaucoma. I want to show you what things look like that are normal. We're looking at here, you can see it says radial peripapillary capillaries around the disc, and we're looking at the superficial vascular plexus within the macula. And again, we're going to kind of get those kind of dropouts in glaucoma that look like wedge defects. So again, here's a normal macula. Here's a normal macula down here, normal optic nerve with the radial peripapillary capillaries. You can see now, here's the dropout that starts occurring in that glaucomatous prozone. You can see that it's matching down here with the thinner and dropout of the capillary. Blue is bad when it comes to reading these. You can see this is an advanced glaucomatous case. You can see the dropout in the macula area and around the optic nerve. So again, we talked about a little bit earlier that, this kind of, here's your axon dropping out and thinning and how it matches over here. You could see it right here as we're seeing how the glaucoma. And what we're looking at with these type of capillary and OCT angiography is we're looking at, you can just see how the capillary wedge defect, you can see the macula is pretty well spared in this condition. This helps solve, like when this starts turning blue, we start getting those macular on the OCT, those macular visual field defects. So how does OCT-A angiography in glaucoma? Well, like I said, it's good. It's not as great as it is. Every patient diabetic of mine gets an OCT angiography. We pick up so much diabetic retinopathy early, and we get them to get their hemoglobin A1Cs controlled so much quicker, and get them a little tighter control. Here it shows early changes of the retina and optic nerve. It adds additional information. It aids in progression and gives us some new information in the diagnosis. So let me just show you what a healthy 25-year-old looks like. We're looking at the different scans right here. This is a nerve fiber layer scan. It gives us a superior and inferior, it gives us quadrants. So it's another nerve fiber layer. We're going to focus on these next few of what the OCT angiography can give us. Here's the macula. Here's your kind of your ganglion cell look. Here's your capillary look. Here's your capillary look. Here's your nerve fiber layer look. Someone that's healthy. Age does not impact. This is a nice, healthy 60-year-old man. You can see the nerve fiber layer looks good. The peripapillary capillaries look good. You can still use the symmetry type of rules, 52 to 53, 52 to 53. You can come over here again, looking kind of at the symmetry that's out there. And you can see we have a little vitreomacular adhesion in this eye that might influence some of the readings. It doesn't look like there's much traction. It's more of an adhesion. You can see there's some traction over here at the nerve area. And again, you can sew these together and you can kind of see what's going on with these patients. And this is just kind of showing off what the instrument can do with what's called an angio montage that's out there. So here we are just showing another, the 60-year-old man, everything looking pretty good. And here they are montaged together. So I'm going to go through this pretty quickly because I'm looking at the time and I want to get through some of at least one or two of the cases to pull it all together. This was a 50-year-old woman that came into the office having ocular hypertension. This is years ago because she was on Travatan. She had ocular hypertension and she was being treated and her pressures were 13 and 14. This was a lady that did not have ocular hypertension. Her nerves look pretty good. They're large optic nerves. Maybe the isn't rule, but I'm going to tell you right now to go quicker that these nerves are perfectly fine. When I checked her diurnal pressures, what happened was her pressures were 16 to 19 and 17 to 20. This was doing a chart review without any medications. This is right around when the ocular hypertension study treatment was being released. And what happened was they said, oh, you have thin corneas. We're going to raise your IOPs. They're probably like 22 or 23. So now, since you have a thin cornea and your pressures are high, now we're going to treat you. So the visual field results, whenever I obtained these, we had this nasal defect. Well, if it's ocular hypertension, we really shouldn't have a nasal defect. But if you look, these are zeros. That's probably a rim defect or a nose defect. So you can look here, the mean deviation, it's saying it's a moderate, mild to moderate defect, and it's very localized. That's what pattern standard deviation tells us. How localized? It's very localized. It's coming from these few little spots right here, while the rest of the visual field has the numbers that we expect. So yes, it's a mild defect coming from these 4 or 5 spots, very localized. That's what we think glaucoma does. Now, this is not a polling question. It's one of my favorite questions. Like, what is the mean deviation on a 24-2 of a blind eye? You know, is it plus? Is it 0? Is it -5? Is it 12? Or is it 32? Because it dawned on me one time, maybe when Joe and I were doing a lecture, I'm like, I wonder what it was during a lecture. And I couldn't wait to get home on Monday to have Sarah run a visual field. I walked in and I said, do me a favor. Can you do me someone that is 35 or 30 years old, run the visual field, they'll never hit it as if they are a blind eye. I want to know what happens. And it was -34. But look, it's very diffuse. A low number means it's diffusely scattered. These are all zeros, -34 in a 30-year-old. I said, do it for 65. It was -32. But again, diffusely scattered. So when I'm treating glaucoma, I don't want my eyes to get to -32. I don't want them to get to -30. I don't want to even get them to -5, but a blind eye is -32. The question that would ask is 16 half blind? No, because it's not linear. That's why a -5 is a big defect on a visual field. So that helps me set my target pressures whenever I'm out there. I use 0 to 5 mean deviation as a mild defect, 5 to 10 as a moderate defect, and greater than 10 as a severe defect. And I usually don't set my target IOP until I get a good visual field and it's off the bad eye, because I know the other eye is going to catch up. So if one eye is a -3 on the mean deviation and the other one is a -6, I'm going to go initially with a 40% IOP reduction. I've been using that for years and it has worked well in keeping these patients from losing more vision out there. It's just kind of a nice little quick and dirty way to set an IOP. Now, how many difference between the two eyes to create an RAPD? Well, it's 3. What I'm saying is if you have a -3 in one eye and a -6 in the other eye, the -6 will have an APD. It's a little tough to see. You might have to use a neurodensity filter, but I can tell you if there's a 5 difference, one's a 5 and one's a 10, you're going to have an APD. So you can check your visual fields or your APD scores that way when you're doing visual fields. So the whole idea here is that this is teaching you how deep it is, and the pattern standard deviation just tells us how localized it is. So this is saying, look, if all the spots were reduced by 1, you're going to have a mean deviation of 1, and it's going to be diffusely scattered. That's what looking at this tells you how deep it is, tells you how localized it is. And then what happens is as it becomes more localized, the number starts to go up, but maybe the mean deviation will stay the same. So here, look what happened here. This was a moderate defect. It was very localized. The other eye had a mild defect, and it's scattered throughout the whole visual field. That's how you use mean deviation and pattern standard deviation that I showed you a little bit earlier. So why is this patient being treated? They were just being mistreated, or they were misdiagnosed with ocular hypertension. They couldn't be in the ocular hypertension treatment study because they didn't have ocular hypertension. I was in that study with Dick Bennett at PCO doing my residency. They had to have a pressure of at least 23 or 24. I forget what the low number is. This patient never had that. We backdoored, or this person backdoored them into it by saying your cornea is thin and then raising the pressure. So we repeated the visual fields. We discontinued the Travatan. You'll see how old this case is because I had a GDX at the time, but we stopped the medication and look, got a better visual field and it went away. Now we're down to -1 and it's diffusely scattered throughout the visual field. And that's what these two numbers will tell us. So you can look how symmetric this whole nerve fiber layer was. They didn't say they had glaucoma, so that was good. We just stopped it and we got this patient off of their medications. So I wanted to kind of set that case up because I got some other cases that we want to do here. So let's do this case here. Let's try and pull this all together, all these concepts that we used. This is a 68-year-old woman with glaucoma. She wants a second opinion on her glaucoma. She recently had cataract surgery in her left eye. She had an eye stent. That's September 25th of 2017. And with the eye stent, maybe one of the collector channels didn't get it in the right spot. How do you predict it? Because you don't know which collector channels are working. So she's still on dorzolamide, 2% twice a day, Lumigan. She comes to our practice. She wants to get another opinion. At that time, my surgeon, and it still is to this day, does Cohook dual blade. Kind of scoops out that trabecular meshwork. And so we have July 24th of 18, one eye with a Cohook dual blade, one eye with an eye stent, and we're still using some glaucoma meds. IOP with Goldman applanation is 12 in the right eye. That's the eye that had the Cohook dual blade. And then we have 16 in the eye that has the eye stent and the dorzolamide and the Lumigan. Now, I still keep a paper chart in my office. I do electronic health records. Yes, everything can get scanned in, but I still like having that dashboard. I still like having that chart. I like looking at it, and it's a nicer. Sarah made a nice little Word document, but we do things. I make sure I do things yearly, and I keep track. What do I keep track of? DFE, visual field, OCT, OCT angiography, gonioscopy, photos, pachymetry. And I make some notes on, I have an area now where it's notes. When they had eye stents, SLTs, Cohook dual blades, allergies to drops, things that I just need to be aware of. So this is our patient that is 68 years old. Here's her pachymetries. So I like looking to see what's going on. Her pachymetries are 575, 586. Again, I start scratching my head when I get about 10 microns different. Maybe she has a little bit of cornea edema. She had a Cohook dual blade in one eye. She had a eye stent in the other eye, but nothing here that's going to cause those pressures, or cause me to have any concern that this glaucoma is going to be, like a more advanced glaucoma or high risk glaucoma. That's all a cornea thickness is. Thin corneas increase risk, thicker corneas decrease risk. Do not adjust IOPs up or down. So here are her scans. Again, she had in the left eye, the one that's with the eye stent and 2 meds, we can see the amount of glaucoma that is. So the glaucoma is worse in the left eye than the right eye. Let's go up to the GCC. That's where I love to start looking. We've got GCC 79 and 70. We've got 86, 81. We got 72. We got 59. We got a 13 difference. We got a 9 difference. We're showing glaucoma definitely worse in this left eye. Jump up here to the nerve fiber layer. We got a 77, 63, 93, 73, 85, and 88. Again, 17 difference, 20 difference, 14. We can see the asymmetry in this patient. In the glaucoma prone zone, you can see, as Joe was pointing out, this kind of just is a continuation. The ganglion cells are dying. The axons are dying, going back all the way to that lateral geniculate. You can even see here we're asking, look, this doesn't look too bad, but we know this is thin. Here, the nerve fiber layer is dropping out. Here we have nerve fiber layer and the ganglion cell dropping out inferiorly. We can see the asymmetry. Here's our visual field defect. It was kind of neat. How would you predict this? How deep is this visual field defect going to be? Oh my gosh, this looks terrible over here. So when we look at the left eye, she's got the visual field index of 78%. Remember, that's 0 to 100. 0 would be paraoptometric blindness. But now I can get a good feel. She's -6. She's just over 5. That's a moderate. But what I don't like either is look how close it is to her macula. It's not that it's sitting out here away from the macula as a scotoma. And then the left or the right eye it's green. It's flagging as green, saying, okay, it's greenish, but you can see 92% and -1.62. Again, glaucoma is usually asymmetric. Definitely worse in this eye. If I knew her T max, I would definitely off of this be setting her target IOP at 40 in both eyes, because I don't want this eye to catch up. So if she had a 26, I would say 2.6 times 4, whatever that comes out to be, about 10 10, 11 millimeters of mercury, I would lower that down as her target IOP from her Tmax. So what did her angiography look like? Here's the radial peripapillary capillaries. Look at this. This is, remember, it's worse in the left eye than the right eye. Nice little wedge defect, kind of matching perfectly with that nerve fiber layer defect. We can see the vascular component. Look at the asymmetry again. We have 95 and 73 on the hemisphere cuts. We could see 118 to 77. Over here, we're not really picking up on the hemisphere cuts, 49 to 48, but we do pick it up here slightly, 50 to that 46, but we can see that nice little wedge defect, how it's matching up. Over here, we can see the nerve fiber layer being dropped out. But what we want to concentrate on is this nice big old wedge defect that's matching. Again, it helps me. It's confirming my diagnosis. It gives me another data point as I want to check progression over time for this patient. I thought this was pretty cool. This is the en-face radial peripapillary capillaries, the RPC. We can see here that we have the nerve fiber, or we have the dropout of the vessels, the capillaries, and look how easy it is to see here. So we can see that kind of helps anatomically make sense of what's happening with this disease. Look how we're cupped out here. Look how this just matches right up. Again, it's not really like, helping me with the diagnosis, but over time, it's going to help me with the progression analysis. How do we look in the macula? Well, here's our GCC. Here's our thinning. Look at this nice little defect that's showing up right here. And we have a defect in this left eye of how bad it is. Look at how the capillaries are dropped out. And the left eye, remember it was in the macula? Look at the capillary dropout. Remember in the visual field? We can still see here that our macula is preserved, or, our fovea is in the center here, but our parafovea is preserved. Our parafovea, it's already into our fovea with this capillary dropout. I'm going to be more aggressive in these patients that have macular involvement. When the macula is involved, it's kind of this little loose rule of thumb that we want to treat these patients a little bit more aggressively. This is just showing off the instrument again, what they can do. The angio montage, you can kind of now understand here what's happening with these patients. This is a pretty good representation when it sews it together. You can see here that the para and para-E fovea areas are not being affected with the capillaries, but you can see here what has happened is this wedge defect, and it's even up into the macula area. So we need to get a little bit more aggressive in a sense on this left eye. It's got an eye stent. It's on 2 medications. This eye is a little bit sicker, than the right eye. That is, and here it is put side by side, a small little wedge defect, macula being spared, if you want to say, but you can see the macula is involved with these scans here. So when I was reviewing this lecture today, I know I have to update these 2 cases. This young lady has now moved to the Philadelphia area, so I don't think I have much to update on her, but here she is in 2021. Here's her optic nerve. You can see the optic nerve and the glaucomatous defect. She's got some floaters in here. These little reflections on the Optomap tell us that she has, intraocular lenses. Here we are just trying to do a little bit of red free to see what's happening with that nerve fiber layer. Again, the PVDs. So over time, you can see what has happened with these visual fields. It's maybe this last visual field, we went a little downhill. I might repeat that. This one here, I did that 24-2C, seeing what's happening with the macula, because the macula was involved with this patient. The right eye, I have no idea why I wouldn't print out a progression analysis, but we can kind of see that we have the right eye controlled over those 3 or 4 years that we've been seeing this patient. How are we doing when it comes to the progression analysis? this must have been a bad scan, so we just deleted it, throwing off maybe the progression analysis. Just looking at the colors, you can see the ganglion cell complex looks like we're doing pretty good, pretty wide with the confidence intervals, and that should be a little bit tighter when they're looking at it. Here we're a little tighter on the confidence intervals. It's flagging the progression on this eye of the nerve fiber layer in this right eye is maybe being a little bit too fast over time. So maybe some progression in this right glaucomatous eye. How are we doing in the left eye? Well, again, you can see the gas gauge is a lot further down, right? We're at 80 microns here. Over here, we were starting with 70. You can see there's fluctuation in this system. And again, look at the confidence intervals. And we can see here it's trying to do a trend analysis for us. And the trend analysis in the nerve fiber layer is flagging it as purple here, saying, hey, doc, it's a little bit quicker than what we want. It's going 2 microns per year. This other eye was 2.56 microns per year. Again, there's a lot of moving parts here, a lot of vitreous, a lot of things going on. So it's not exactly, it's kind of, a little bit of a, I don't want to say suggestion, but hey, doc, take a look at it. Doesn't mean that you have to, but just keep your eye a little closer on it. Maybe run some visual fields a little quicker based upon some of this data that we see. Now, this is where, maybe the angiography comes into play. We're looking at the radial peripapillary capillaries from 2019 to 2021. Right eye, here's the left eye. We've got the right eye here, kind of going straight across, maybe the left eye going a little downhill, a little straight across, a little downhill. So that left eye, again, is that sick eye. Maybe need to get a little bit more aggressive over there, but certainly not crashing and burning in the 3 or 4 years that we've been following this patient. The wedge defects, as we go and look at you got the right eye kind of going uphill now. We have the left eye either straight across or a little downhill trend. So again, the angiography is just another nice data point to have. It's not as wow as macular degeneration and glaucoma. And we can kind of look here now as we look at the GCC analysis is what I have clicked here. That one's going straight across, maybe a little downhill, a little uphill, and just things seem to be controlled when we look at this data here. So what does the macula superficial vessel density look like? Well, we got one going uphill, the right eye. That's the one that had the Cahook dual blade. This over here where the glaucoma is a little bit more aggressive, maybe a little bit of a downhill trend. When we look at again, it's right here, the vessel density superior, we can see that this area is still sparing the macula in 2021. And we can see here that the macula is still involved. This macula is still okay. It seems to be pretty stable when it comes down to the vessel density. Again, it's a nice piece of equipment to have, again, to kind of augment with the structural changes of GCC and the axons that are out there. How does the deep plexus look? We can see here on the right eye, that the macula is spared. The deep plexus is spared here in the left eye. All right, Joe, anything you want to make comments on that case?
No, but we have some, I think we have some questions in the chat, which are pretty timely. One question, what PSD is representative of glaucoma? I don't think we have an answer for that, but you want to take a shot on that?
I missed the first part of the question.
What pattern standard deviation is representative of glaucoma?
Yeah, what pattern standard deviation? There's no pattern standard deviation. Just remember that in glaucoma, it keeps getting deeper and deeper. Then in more advanced glaucoma, when the superior part starts or the inferior starts, it will start to get lower. So that number starts to reverse. That could be that the glaucoma is getting worse because the other side is becoming involved. So there's no number for that.
if glaucoma is a neuropathy, why is there concurrent loss of capillaries on angiography? Is this finding saying that glaucoma is not just a neuropathy, but a vasculopathy? I think it's a thought-provoking question, Greg. I'll let you take a first shot at that.
Well, yeah, I'm going to flip it back to you as our optic neuropathy and neuro phone a friend on this one. So
the answer is the nerves need nourishment. So is it a vasculopathy? Is there something there that is not? Yeah, I mean, we got the supply of the short posterior ciliary arteries, supply or the ciliary circulation supplying, basically all aspects of the anterior laminar and retrolaminar part of the optic nerve. So ultimately, capillaries come from that. So if there is a loss of of the ciliary circulation, it bears to reason that you're going to have loss of retinal capillaries. Another way to think about this is, let's say you've got a patient with a sixth nerve palsy. That is neural. I mean that you have a nerve that is not working. Why is that nerve not working? If it's ischemic, it's because the vasa vasorum has seized up, and that nerve is not getting the nourishment it needs. So there is a correlate here. It is both. It is a neuropathy that has a vascular component to it.
I'm going to go through this case really rapid. When I'm putting this case together today, I realized that I still see this gentleman. I'm going to update this case, but I'm just kind of showing you here how I use that dashboard, making sure I get everything. You can see his baseline was 85 and 35. He's on Lumigan and Comigan. I think that's changed up. He's had cataract surgery since then. But I want to go through here quickly is that this here, when I point out, look how deep this biggest visual field defect is. It looks pretty scary until, that's why I have this purple box here, until I take this away, and then it only says 1.3. So this looks huge, and it is. It's diffusely scattered. You can see that here. It's a 2.9. But if I take that away, you'd probably say, "Oh my geez, that's like a -5. Maybe that's a 10." But when you take away and you kind of exhales a little bit, that defect is only, it's still there. I shouldn't say only, but it's a 1.3 over here. He's in the plus range. No glaucomatous damage on the visual field. We can see that we've been doing pretty decent over the many years of treating him on the visual fields. I want to point out real quick, I'm going to do this super fast because I want to go through the last case super fast too, but I want to make sure we land on time. Here's our 13. Here is our nerve fiber layer being asymmetric. You can see it's flagging it being worse in the left eye. You can see the nerve fiber layer and the GCC loss that is with this patient. All these concepts, this is what I need to update because I just saw him recently. We can go all the way to 2024. I can tell you he's doing stable. He's doing great as we follow him. You can see what's happening with some of the radial peripapillary capillaries that we're following him with. And his macula scans, you can see that there's dropout that is associated with this glaucomatous damage. Really nothing showing up in the right eye, really not showing up much in the left eye. We caught his glaucoma early for this. You can see his nerves are not screaming glaucoma, but we can see the glaucomatous damage in this area right here of his left optic nerve. Again, we can see it here in some of the wedge defects that's out there. So we've been doing a pretty good job taking care of him. He's kind of even going uphill in this eye. That can happen as you heal and let things, you can see, oh my gosh, how big this is. What's going on? Oh, it's 1.6. In 2010, it was a 64. It was an 85. So we're doing pretty good with his glaucoma treatment. Again, nice and tight on the progression analysis, and I can even go out further. I have this guy pretty well controlled for the 10 years that we've been treating his glaucoma. It's kind of flagging it here as a little bit too much progression, but we've been watching him closely. And then the nerve fiber layer does this pretty good here with the help. All right, I'm going to do a quick case here. This is a guy I've been following, and he's probably 53 now. ocular hypertension 2014. When I worked at another office, he followed me over. I got all kinds of data on him. I've been following a guy with pressures of 35 for 10 years. And so I just want to show you some of these concepts. You can see here, he's 99%, he's 100%. There's no visual field defect that he has. But this is where interpreting these become important. There's a guy with the pressures of 30s in both eyes, 30, 38. I'll show you some of the auras. But look here, the ganglions, the nerve fiber layer is 0, 1, 0. Oh my gosh, look what's happening here. We got some reds, but no, hold on. 81, 81, 80, 79. We're all within a few microns. Look, it's not glaucoma, it's general loss. Look at this yellow here. We would have been lulled in with those pressures that he's got ganglion cell loss until you apply some of those concepts. Look how beautiful this is, all symmetric. He's a high myope. He's like a -8. That's why he's thinned in his macula. And we can see here that his radial peripapillary capillaries look good. And this is where all these tests here are helping me whenever I look to just say he's a physical therapist. He gets risk, he gets benefits. He doesn't want the drops in his eyes if he doesn't need them. He said, "Doc, show me damage. I'll take drops. I'll do SLT. But for now, you're just going to follow me." Right here, 38.5, 32.9, 31, 28, 30, 30. We've been following him. He's still running high pressures. We're running all the tests on him. Here's his optic nerves. Running high pressures, not getting any glaucomatous damage. For 10 years, we've been almost 10 years, because I started seeing him in 2014, and this is 2024. If I would have treated him in 2014, I would have been patting myself on the back saying, "Man, look how good we are. We saved your vision." I didn't do anything, and we still saved his vision. But I told him he's probably going to convert to glaucoma at some point. But this is how, using the OCT, he's going straight across. I can tell you, in the last 2 years, he's still going straight across. This here is flagging it as a little bit maybe downhill. This one's going uphill. Again, I put a little bit more weight in the GCC. When we come and look at the analysis of his angiography, we kind of got a mix, one going downhill, one going straight. Nothing here have I seen of anything that is glaucomatous damage. Maybe one going downhill, one going uphill. Now we're kind of meeting in the same area right here over time. These going straight across when we look at the radial peripapillary capillaries. And again, straight across here when we look at the GCC thickness analysis. So he's had pressures of 38, 32. He's got ocular hypertension, and we continue to follow him. So how does OCT-A help us? It shows early changes in the retina or optic nerve. It just adds additional information and would help us with if we think that there's progression. So with that said, the last slide, if there's any other questions, Joe, is...
We'll launch it first. And... hold on 1 second.
And the other thing that has launched is the survey. If you guys look at the survey, I can see that there's a little red dot. And if you launch that survey, you can... Sure. Really just, I feel more comfortable in interpreting an OCT and OCT for the diagnosis management of glaucoma.
Couple quick questions. How frequently do you perform OCT and visual fields on your glaucoma patients? Have the advancements of OCT imaging changed the frequency of fields? Those are good questions.
So the frequency of a visual field in OCT is yearly. OCT, maybe the shortest I'll do it is 9 months. Unless I'm having maybe a really bad secondary glaucoma and the pressures are just hard to control. And I know I've got nerve fiber layer drop out, and I'm just trying to see if there's anything rapid going on. Do I have to get them to some type of surgical consult? But OCT is pretty much 9 months at the shortest, definitely yearly. Just doesn't, in my mind, change that much. Now, visual fields, the more advanced the glaucoma, the less I do OCTs and the more I do visual fields. And I do 10-2s on some of these patients and 24-2. So the more severe the visual field, the more frequent the visual fields. I have some patients doing visual fields Probably the most frequent would be 3 to 4 months on some of the advanced glaucomas. But definitely yearly for a visual field, most patients yearly for the OCT, more aggressive glaucoma, more frequent visual fields, and probably the more I would do an OCT would be about 9 months, unless there's a
Yeah,
special situation.
hey, I like fields every 6 months. The last question I'm gonna field it if you don't mind.
Yeah.
From Maria, is there any concern for a CRVO in a patient with high untreated pressure? The answer is no. Maria, in my career, I've seen many patients, pressures 50s, 60s, and 70s. I've never seen a vascular occlusion in any of them. I've seen CRVO in glaucoma patients because of concurrent ischemic vascular disease and comorbidities, but those are CRVOs in people who are being treated and whose pressures were quote unquote well controlled. But I said I've seen pressure in the 70s, and I've never seen a vein occlusion yet from that I can say was from that. And have we ended the poll, Greg?
I switched over to the chat. If you want to end the poll. I didn't get to see the results though. Hoping that they were good.
Oh, the best. Everybody agrees.
All right, perfect.
Strongly agree. Nobody disagrees. She did a great job. Greg, you should probably say, you should give him 3 choices: strongly agree, and wicked agree, and just get rid of disagree. Nobody's going to say that because you did a great job.
Oh, well, thank you. You're very kind. Thanks, audience. Again, what Joe and I try to do here, and it sounds like all the questions are answered, is that we try to make something that's clinically relevant for you to go to. And if you're going to work on Monday, tomorrow, hopefully if you're doing OCTs, this will help you to interpret them.